Welcome all. Today's presentation is about external cephalic version and reducing the incidence of term breech presentation. It is a green top guideline number 20A. It is published in 2017, March 2017. So what is the success rate of ECV? It is 50%. Again, this is one of the SBA they can ask you, what is the success rate of ECV? It is 50%. Okay. After unsuccessful ECV at 36 weeks, few babies turn spontaneously to the cephalic. Again, there is a SBA here. We will discuss later on. Few revert to the breech after successful ECV. So percentages of each they are expecting. Okay. Like what is the success rate? It is 50%. Okay. After successful ECV, how many will become breech? That sometimes they can ask you. If the ECV is unsuccessful, how many will have a spontaneous cephalic version? That also they can ask you. Okay. Successful ECV reduces chance of caesarean section. Labor outcomes. So labor after ECV has slightly higher rate of caesarean and instrumental delivery compared to spontaneous cephalic. Now, how will you predict the success? Some prediction is possible, but models should not be used routinely to decide eligibility. So there are predictive models, but they are not indicated. Now, how you can improve the success rate of ECV? It can be improved by tocolysis, that is beta mimetics will improve the success rate. Then routine regional or neuraxial analgesia is not recommended. May be considered for repeat attempts or if ECV is intolerable. So mainly tocolysis, but routinely analgesia or neuroaxial analgesia is not recommended. It can be considered only for repeat attempts or if ECV is intolerable. Okay. What is the timing? It is around ECV offer to be offered around at or after 37 weeks. Okay. And for nulliparous women, it may be offered from 36 weeks. For nulliparous, remember 36 weeks. And for multiparous, you can offer at 37 or more weeks. Okay. Are there any contraindications? There are no universal consensus on contraindications. So ECV after one caesarean is not a riskier than in unscarred uterus. So even if it is a case of previous one caesarean section, ECV after one caesarean is not riskier than unscarred uterus. So it is risk is almost same. So there is no consensus on the contraindication. Then what are the risks? Very low complication rate when precautions are taken. Fetal safety measures perform only where monitoring and surgical facilities exist. Pre-op cesarean preparation is not required. What you need is electronic fetal heart rate monitoring post ECV. Okay, so you need to monitor them fetal heart rate very well, and anti-D prophylaxis for RH negative women after testing for fetal-maternal hemorrhage. Who should perform? Only by trained practitioners or trainees under direct supervision. Acceptability, women will tolerate this, but sometimes it can be painful. Okay. Then developing and auditing ECV, not asked, so we'll skip this. What is there any role of non-ECV methods in which you have moxibustion at around 33 to 35 weeks? It may be considered under trained guidance, and postural management alone has no proven benefit in turning breech to cephalic. Postural management alone. So, role of non-ECV methods such as moxibustion at around 33 to 35 weeks of gestation may be considered under trained guidance, and the postural management alone has no proven benefit in turning the breech to cephalic. Okay. Now, let's go into the details of the guideline as such. Now, external cephalic version, that is the manipulation of the fetus through maternal abdomen to cephalic position. What is the aim? It reduces the breech at delivery time and reduces the cesarean and its complications. So overall incidence of the breech at term is around 3 to 4% of all deliveries. It is more common in nulliparous and preterm. Vaginal breech delivery is rare after term breech trial. Vaginal breech delivery rare after, because most of the patients underwent caesarean section. Okay, that is why ECV is important now, because effectiveness of ECV overall success rate is around 50%. Okay, it is 60% in multiparas and 40% in nulliparas. This you please remember. If they ask you about overall success rate, it is 50%. If they ask you in multipara, they may give you the history that she is gravid to para when living one and she is asking for success rate. Then your option will be 60%. Okay. If she is primipara, nullipara, then it will be 40%. So please read carefully and then select the appropriate option. Few turn spontaneously after failed ECV or after 36 weeks, that is 3 to 7%. Okay, so these figure that 3 to 7%, how many percent you have given the option of ECV. ECV is tried, but it has failed. Okay, then still there is a chance that 3 to 7% will become cephalic. Okay, and you have done the ECV, it is successful, but still there is a 3% chance that it will become breech again. Okay, so ECV reduces non-cephalic at delivery, relative risk is 0.42. ECV reduces cesarean risk, odds ratio is 0.57. Okay, these odds ratio and relative risk are not asked. Okay. Now, labor outside tocolysis with beta mimetics is indicated. However, nifedipine, atosiban, glyceryl trinitrate, they are not effective. Regional anesthesia may reduce failure rate and force is required. Okay, but no evidence of increased complications. Not for routine use, but helpful in women who cannot tolerate ECV. So, regional anesthesia not routinely indicated. Okay. Then when to offer and what are the contraindications? ECV is to be offered from 37 weeks in nulliparous women, from 36 weeks in nulliparous women. Otherwise, it is 37 weeks. So in nulliparous, it is 36 weeks. Otherwise, at 37 weeks. No upper limit gestation limit, but contraindications will increase with advanced gestation. Okay. ECV before 36 weeks, there is no benefit, increased risk of preterm birth. Intrapartum ECV is possible if membranes are intact and no contraindications. Sometimes this option can also be selected for the scenario if the membranes are intact. Okay, so if the patient is in early labor, there are no other high risk. In that particular case, this option, because there are no as such contraindications for ECV. Okay, it can be considered with unstable lie during induction. Then what are the contraindications? No universal consensus. Then clear contraindications will be placenta previa major, placental abruption, severe preeclampsia, abnormal Doppler, CTG, etc. Generally, it is contraindicated in multiple pregnancy, except in second twin, RH isoimmunization, then recent vaginal bleeding, ruptured membranes, abnormal electronic fetal heart monitoring, and refusal of the consent. So these are the in general contraindications. Use caution with oligohydramnios and hypertension. So these are not absolute contraindication, but they say that caution is oligohydramnios and hypertension. After one cesarean section, it appears safe. Okay, so they may confuse you by giving a history of previous cesarean section. Okay, so the option may still be ECV. Okay, now what are the risks? Very low complication rate when precautions are taken. Risks are rare, but the placental abruption is known to happen. Fetal-maternal hemorrhage, emergency cesarean section in less than 0.5%. Okay, that means you do the ECV and you need to shift the patient because of the abnormal fetal heart rate immediately, either during the procedure or immediately after. That is around less than 0.5%. Remember, okay, no increased prenatal mortality or adverse neonatal outcome. Unsuccessful ECV may slightly increase neonatal unit admission rate. Fetal-maternal hemorrhage occurs in around 2 to 3% cases, and sometimes it is more than 30 ml. Then what are the fetal septimages? Perform only where monitoring and surgical delivery facilities exist. Pre-op cesarean preparation is not required. Only facilities should be available. Otherwise, patient should not be prepared for cesarean section and to be taken for ECV. Okay. Then electronic fetal heart rate, we should check before and after ECV. Ultrasound to confirm FHR. Transient bradycardia less than 3 minutes is common. Persistent for more than 6 minutes, then you will go for urgent cesarean section. Okay. So if your scenario mentions this, there is a transient bradycardia, look for the duration. If it is 3 minutes, it is common. So monitor the fetal heart further. But if it is persistent more than 6 minutes, you will prepare the patient for the urgent cesarean section. And you will give anti-D prophylaxis for RH negative women within 72 hours or Clavin's test to guide dosing. Okay. Now, what are the attempt limit? To less than or equal 4 and maximum should be 10 minutes you can apply in each attempt. Okay. Who should perform? Only by trained practitioners or trainees under direct supervision can do this ECV. Training reduces complication. Competence required in advanced obstetrical training. Okay. Then acceptability of ECV. Generally, most of the women will tolerate ECV, but sometimes it can be painful. 9% may decline, maybe because of fear of pain, vaginal birth, or negative stories, etc. 1/3 will experience significant pain. Median pain score is around 5.7. 75% describe as uncomfortable or worse, and 5% report severe pain. This is from one of the study. Okay, but satisfaction is higher if ECV is successful. Now, how can you improve the uptake? By best improved by the timely breach identification and evidence-based counseling. Breach often missed at term around 25% cases. Okay, 30 to 32% cases, and these are the cases where you get a worst outcome. The breach which are missed and they present directly in labor will have a worst outcome. Then abdominal palpation sensitivity is only 70%. Routine presentations scan after 36 weeks is important, especially in high risk. Previous breach recurrence rate is around 10%. Women more likely to accept if the benefits and risks are explained clearly. So these are the things which we should talk to the patient. There are models which are available, but these models are not indicated for predicting the success rate and all. Then is there any role of non-ECV? That also we have seen. Moxibustion and postural management alone is not suitable, and moxibustion at around 33 to 35 weeks may help, especially with postural management or acupuncture. So these two combined can be tried. Okay, so that finishes the external cephalic version. Thank you.